We'll start out with a little bit about arthritis, then we'll go to what are the goals of treatment, what are some non-operative treatments that we can do, and then finally to the operative things and some pictures. So when we get to the picture part, you can feel free to interact, raise your hands. If you can't hear me at any time, just let me know. So arthritis, what is it? Well, in simple terms, arthritis is destruction of the smooth gliding surfaces of your joints. And it's called articular cartilage. And what happens is there's a process where that cartilage is damaged that subsequently leads to pain, leads to decreased motion, leads to problems with activities of daily living, and it also can lead to such deformity, particularly in the hand, that it makes it difficult to do things because of the deformity associated with the disease. Now, your body's made all the cartilage it's going to make, so we can't command it in any way, shape, or form to make more cartilage, and that therein is where the problem lies. When that cartilage gets damaged for whatever reason, we have no way of growing new cartilage. We can take cartilage from other areas and replace it with certain very small lesions, but that's technically very difficult and often isn't done because the arthritis is too widespread. So, types of arthritis. There's probably dozens of different types of arthritis, but basically they fall into the categories of one, which is osteoarthritis. That's probably what most folks have heard about. It's degenerative joint disease. That's a wear and tear pattern of arthritis, and that's the most common. There are some hereditary factors to that as well, but not as much as some of the other patterns of arthritis. So one, osteoarthritis, wear and tear arthritis. Number two is inflammatory patterns of arthritis. So that would be like a rheumatoid or lupus or scleroderma or gout. And what that is there's significant inflammation, sometimes which the body even mounts a defense against itself and attacks the cartilage cells and the tissue around the joints, and then you get the cartilage destruction, pain, decreased motion, and deformity. And there are two other types. One is post-traumatic arthritis. Now that can be if you're playing football in college or you fall off the ladder and you dislocate your shoulder or your elbow. That cartilage can be damaged when those joints scrape together in a way they're not designed to do. That is a traumatic damage to the cartilage, and you subsequently have thinning of the cartilage and develop post-traumatic arthritis. Then there's septic arthritis, and that's one that we never want to see or get, and fortunately it's quite rare. That's where your joint will spontaneously develop an infection, and that infection is caustic to the cartilage and tissues of the joint, and you subsequently develop arthritis because of the infection. So what are the goals of treatment? Well, goals are we want to decrease pain. That's the number one thing that people come in and talk about arthritis for is, this hurts, doc. And the next thing they'll say is, I've lost motion. I can't get up on the top shelf anymore. I can't get up here and wash my hair anymore. So pain, lose motion, and problems with activities of daily living. So we want to, one, we want to help you relieve pain. Number two, we want to help restore activities. And number three, if we can, we want to stop the progression of the disease. People will often ask that have osteoarthritis, hey, what can I do to stop this from getting into other joints? And the simple answer is nothing really. It is going to do what it's going to do. Now, some of the inflammatory patterns of arthritis, there have been huge steps in the last 10 or 12 years from a medication standpoint, rheumatology, to have disease-modifying drugs that have really changed people's lives. And so from the inflammatory standpoint, there are lots of medicines and things you can do. So treatment options. Now, one, I have to give a disclaimer. So I'm going to talk about some anti-inflammatory medicines and steroid injections and those sorts of things. And before you randomly start on any sort of anti-inflammatory medicine, you want to check with your doctor. You check with your family doctor to make sure that's not going to interact with any sorts of other medicines you may be taking. Now, my parents are always, they're calling me because they've been given something and they read those interactions and they're this long for everything. I mean, we probably wouldn't take any pills, but there are some that are serious, particularly taking blood thinners of in any sort, and then combining those with anti-inflammatories can have some real problems. So those are things you want to make sure you can take. I'm going to give you some suggestions on things that we do, but as far as specific medications go, make sure you talk with your family doctor. So, treatment options. One, everyone's probably heard about glucosamine chondroitin, okay? You can get a jar of that at Costco for 20 bucks or something, and I think the literature is still out on that. Does it help? Does it not? Now, of course, the people that produce the medicine, they want you to think that it works, and they produce studies that say that it does, and they may well be right, but we're still waiting on definitive answers for various kinds of, do these chondroitin sulfates or chondroitin hydrochlorides, do they help? I have patients who take them in the early times of arthritis when it just kind of gets started, and there's some evidence that shows that it may help preserve cartilage. They do not grow cartilage. Okay, so if anyone tells you it's going to grow cartilage, you want to run away from that right away, because it won't. But it can help preserve cartilage. So chondroitins can be helpful. Once you get bone-on-bone arthritis on your X-ray, probably not much benefit at all to taking that. The other things are non-steroidal anti-inflammatory drugs. Now, simply those are Motrin, Advil, ibuprofen. Now, all three of those are the same. They're just different names. But basically, they're all ibuprofen. So you have Motrin, Advil, ibuprofen. Over the counter, those will come in 200 milligram pills. And the important thing about anti-inflammatory medicine is that you take a little bit of it every day. That's better than a handful today and a handful next week. You want to help build that medicine up in your bloodstream so that it can help decrease inflammation. So that kind of goes everywhere. And lots of times people will say, I don't think that works, Doc, but I've been taking this. And then we do a surgery on them, and we take them off that medicine for bleeding purposes during surgery, and they come in and they say, that medicine was working because I can hardly move. So sometimes it's like watching your hair grow. You don't really see it from day to day how much the difference is, but it can make a difference over time. So non-steroidal anti-inflammatories. Aleve also fits in that category. Okay, and then there are prescription anti-inflammatory medicines that are touted to be a little more potent, and you need to get a prescription for those medicines. Now, Tylenol helps with pain. Tylenol tells your brain not to hurt for 3 or 4 hours, but it really doesn't do a lot to decrease inflammation. But the nice thing is, as long as you don't have contraindications to that, you can take Tylenol and you can take anti-inflammatories at the same time. Again, with GI precautions, liver precautions, and that sort of thing. So please let your primary care doctor know about that. The other things are modifying activities. You know, some people will come in and say, I have shoulder pain and I cannot throw the javelin like I did 50 years ago in college, okay? You need to stop throwing the javelin, okay? You can remember the glory days, but don't try to really relive them. You can find something else to do. Now, people will come in and say, yeah, this has been bothering me at work for 2 or 3 months, but now, Doc, I can't fish. Okay, well, that's serious, okay? if you have trouble at work, that's one thing, but if you can't go fishing, that's completely different. But so modify the activities that you do. Now, upper extremities, not really so important, but lower extremities, those are weight-bearing joints. Okay, hips, knees, ankles. You're pounding on those all the time. So if you have increased weight on those joints, that's going to be a bit of a problem. The issue there, though, is that it's a tough thing to do to try to exercise more when your joints hurt. So it's kind of a vicious cycle. But getting weight off of joints is important. Again, not so much in the upper extremities, we don't deal with that, but in lower extremities it's important. So modify your activities or perhaps get on an exercise program. Now, most of the time arthritis responds positively to some form of exercise. You don't want to let these joints get stiff. You don't want to not use them. But it's unloading type of exercise. You know, it's not powerlifting or CrossFit anymore. It's swimming in a pool or, don't tell anyone I said this, but doing yoga okay? That can be helpful because it keeps your joint, it keeps your muscle stretched, and flexibility as you age is very important. The other thing is physical therapy or occupational therapy for the hands. Now, again, that's problematic sometimes because someone with an arthritic shoulder or elbow, they want to try to get more motion, they go to the therapist and it hurts, and they give you exercises and you take them home and you read the sheet and you do it and it hurts. What's going to happen after not very long? You're going to stop doing it. And that's okay. Your brain tells you, stop doing that, it hurts. So that's okay. But that's what's hard sometimes about therapy for primary types of arthritis or inflammatory types of arthritis. Now, therapy, I will say, is very, very valuable postoperatively in recovery from those sorts of things. But preoperatively, sometimes the benefits are difficult to achieve. I'm just about done with the boring part. The other thing is steroid shots, or cortisone shots. Now, there are different types of steroids we use, but basically what we do is we wash the hand or the shoulder or the elbow and we put the shot inside the joint. Now, that's anti-inflammatory medicine that goes right into the area of problem. Now, there is some of that will get into your bloodstream, so if you're diabetic, make sure you tell your doc about that if you're going to get a steroid shot, because that can elevate your blood sugars some. But most of that shot stays right in the joint. How does that work? I'll be honest with you, I don't know. Okay? But I know if we didn't have vials of cortisone in our office, it would be a lot harder to practice because it helps people. And we have people that are not good candidates for surgery for heart or lung reasons that come in and frequently get steroid injections just to help them maintain some motion in their joints. We have other people that aren't quite ready for surgery yet, and we'll put in a shot every 3 or 4 months, and they come back again. That's okay. As long as the shot's getting in the right place, I think that's okay to do that, and it helps you avoid a big operation. Now, we've heard about viscosupplementation. Now, I'm not able to say what those words, but rooster comb, you may recognize it as that. There are various types of that out there, and again, this is a synthetic reproduction of naturally occurring joint fluid. And it's used widely in lower extremities. In the upper extremities, very limited use around the shoulder perhaps, but other than that, it's not really recommended. So in the knees and ankles, I think it's very helpful, but we don't use it much in the upper extremities. So what happens if these things we talked about fail? And I'll tell people, you know when it's time to do something operation-wise. And some people come in, I just can't take it anymore, and they're ready to go, and then you talk about what we're going to do, and then they say, well, maybe I can take it a little while longer, and then they leave. Again, which is okay, because if you're going to go get something done operation-wise, you want to be all in. And that way you're going to do what's necessary to try to get it better. If it's, well, I think it hurt last Wednesday when I was moving, no, that is not something that you want to have an operation for. Okay? Arthritis operations are not restoring normal joints. They're what are called salvage operations, meaning we're putting metal and plastic in the place of what used to be smooth gliding cartilage. Okay, it's different. It's not going to be like when you were 20 years old. Okay, it's not going to be that way, but it is helpful. Okay, so surgery-wise, we talk about what are some things we can do. Sometimes we can do a limited surgery, arthroscopically in the shoulder. We go in, we decrease, we take out inflammation, we take off loose pieces of cartilage, and that can be of benefit. I will say generally that's short term. Okay, now that's not always true, but generally it's short term because the progression of the arthritis goes onward. We say when we do arthroscopy, that's when we go in a shoulder and look inside with a TV camera or an elbow or a wrist and we wash things out. We're washing out the bad humors, okay? So it helps for a period of time. And if you have a large cartilage flap or a piece of that tissue that's flipping around in there, that can be very beneficial. But for moderate to severe arthritis, they're usually just kind of chasing your tail with that operation. So the next thing we have joint replacements and we have joint fusions. Okay, now keep in mind the goals of these are decreasing pain, decreasing progression of the disease, and restoring some function. Okay? So we have joint replacements, which are often for the shoulder, for the elbow, less frequently. And there are joint replacements for the wrist, but not many folks do that much anymore. There are fusions that we do, and we'll talk some about this as we go through some x-rays here. So I'm going to show you some pictures now, and we'll just kind of talk about them as we go through here. So here's an x-ray of a shoulder, and I have to try to be coordinated here. All right, so here's the lung right here. Here are ribs that come down right here. Here's your collarbone that comes over here like this. Now, this is the outside of your shoulder over here. This is your ball joint right here. And this is your socket joint. Now, if you look at this x-ray, so that's a straight-on view, and this is a side view. So if you look at these x-rays right here, this is kind of what a normal shoulder would look like. So you have, we look at where's the ball joint in reference to the socket joint. Well, it's in good position here. Look at that clear space. So one thing about cartilage is cartilage doesn't show up on an x-ray. So when you have cartilage, you have a clear space between the bones. And that'll become readily obvious here in a minute where you don't have a clear space. But see, you have a clear space right here. So that's a nice shoulder with nice cartilage. Now, they may have a rotator cuff tear, they may have something else going on, but they certainly don't have much in the way of arthritis. If you look at the side view here, this is the ball joint here, this is the socket joint, this is the front of the shoulder, this is the back. Again, there's a nice clear space here. So one thing we know this person does not have is ball and socket arthritis in the shoulder. Okay? Now, let's look at this one. This is a different story here. Same thing, left shoulder, lung over here, collarbone coming over here. This is part of your shoulder blade. It's called your chromion. Now, here's the outside of the shoulder. Here's the ball joint. Look here. There's not a clear space there, is there? There's a white area here. That's called sclerosis, and that's when the cartilage all dies. The bone, when you get in there, is like the countertop here. You can't hardly even, so hard a cat couldn't scratch it. But it's hard here, and it forms this sclerosis on either side. Now, your body's tried, like we talked about, it's made all the cartilage it's going to make, so it tries to do something, and it lays down bone. So you get this bone spur right here, and you get this bone spur here on the socket side. So this person has bad ball and socket arthritis, right? No joint space there. Now, this is a side view, and you can see the same thing here. There's just no joint space left. This is important for surgical planning because we see, is the ball joint in the socket joint in the right position? The answer is yes. It looks good there, but it's a very arthritic joint. Okay? Now, does this person need a shoulder operation? Well, it depends. I mean, how much does it hurt them? Okay, we don't operate on x-rays. We operate on people. So if they have this x-ray, and they hurt all the time, and a big thing with shoulders is I can't sleep at night, and if you can't sleep at night, somebody next to you can't sleep at night, and that gets old really quickly, okay? So if this hurts at night, you can't sleep, you have pain, we've gone through the non-operative things, well, then we talk about doing something operation-wise, okay? Sometimes that scares people off, and other times they're like, I got to go for it. So if you decide to go for it, here's what we do. We go into surgery through a big incision. It's not pretty. Many times incisions that heal well, it has nothing to do with the doctor. Don't tell anybody that, or the surgeon. It's just where it's at on your skin. So sometimes we'll be, you did this so well. Yep, we did. But it has nothing to do with what I did. It just heals well there. So just a little tip. But so here's outside of the shoulder here. So we go through the shoulder with a big incision. Now, to get access to the ball and socket joint, we have to cut through one of the big rotator cuff tendons. There's a big one in the front. It's called the subscapularis. And so we cut through that, and that's the biggest deterrent short term to recovery is coming back out. We have to repair that. So you have to let that heal. All right, so we go in and we cut off that nastiness. We just cut that off right there. And then we go down through the marrow part of your bone here, and we put the stem in here, and then we put a metal head. So you've got some sort of expensive NASA titanium plus stem in here, and then you have a metal head on top of that. And then we do the socket side. Now, sometimes in shoulder surgery you can't do the socket side. And it has a lot to do with, have you had previous surgery, is there scarring? But the shoulder has what's called a lot of version in it. And that's just normal anatomy. It may be the way you're built, but it faces somewhat backwards. And if you have a lot of scarring and it faces backwards, it's really hard to do the socket side. That's where you earn the money doing a shoulder replacement, is on the socket side. But the people that can get both the ball and socket done, they're the ones that do better. Okay? So then what we do is we drill holes in the socket over here. First of all, we scrape all the arthritis off, we drill a hole in it, and then we put this implant in that has little pegs in it. And I wanted to try to have some to pass around, but I didn't get into it. So plastic over here, metal here. And then all the tendons and things are still around the shoulder. So your tendons drive the shoulder, and you're not just bone grinding on bone. And it is one of the happiest things that we do. We had 2 people come back this morning, and I got a new medical student with me, and these people, they're moving their arm all around, and he thinks I'm really great. And I'll just wait till another one comes back. But they feel better. In 2 weeks, they feel better. Now, they can't sleep on it for 6 weeks or so sometimes. You have to sleep in a recliner and that sort of thing. And there's a good bit of therapy afterwards, and we have to let the tendon heal in the front, but it's a good operation. Okay? Now, here's another shoulder. So this one has some arthritis here. Remember our ball and socket joint here. But this one's different because we're going to go back. You see the space between here and here? Now remember that space. That's where your rotator cuff tendons go. Look here. There's not much of a space there. So this is a bad deal. This tells us that you have arthritis in the shoulder and you have no rotator cuff tendons to drive your shoulder. So what do you do about that? Well, when the ball joint has already migrated up, you generally can't go in and repair those rotator cuff tendons. So this is what's called rotator cuff arthropathy. Until about 15 years ago, I guess I'm older than I think, maybe 12, 15 years ago, this was an unsolvable problem. We could go in and we could do clean out to clean things out, but it never really worked that well. Because to do a normal shoulder replacement, you have to have tendons to drive the shoulder around. This person will come in and you'll say, move your shoulder, and they'll do this. Because they can't lift their shoulder. And that many of them will report, doc said I tore my rotator cuff 15 years ago. And they did okay for a while. And then when this migrated up and they started to develop arthritis, they have pain. So again, we go through the same routine that we did before. We give pills, we put in shots. If these don't work, this is a different type of shoulder replacement. It's called a reverse shoulder replacement. Okay, now you don't have to get all fancy about knowing about this, but what it is you put the ball on the socket side and the socket side on the ball side over here. And I don't remember his name, I think he's a French fella, but he's pretty smart. He said, well, you don't need a rotator cuff with this construct. You use your deltoid muscle to work the shoulder. So this type of operation is a good operation for expectations of pain relief and being able to sleep on it at night. Now, nobody becomes a power lifter after this. I mean, you may be able to get up to here. A victory with this is being able to touch the top of your head, okay, with good pain relief. This is someone who has chronic rotator cuff tear of their shoulder. They get this type of replacement. Okay? Thank goodness there are smart people that think these things up. All right, so here's an elbow. This is a fella that I've known forever, and he's a rascal. He is a goer. He does all sorts of things. He breaks his own horses. He does farming, ranching, and we've operated on him half a dozen different places, but never his elbow. But what I'm trying to tell you here is that the elbow is interesting because it tolerates things pretty well. Now, the shoulder has all sorts of different planes of motion, as does the wrist. The elbow is basically a hinge joint. It goes up and down. So when you lose motion in your elbow, how do you compensate for that? With your shoulder or with your wrist or your fingers. Your shoulder positions yourself in a different place in space, and you can do things. So just looking at this is the outside of the elbow, this is the inside. Well, he's got a terrible joint space here. He's got bone spur here. He's got a big loose piece of bone that's broken off here, bone everywhere, and no cartilage. And he doesn't really even hurt. We x-rayed this because we're going to do another soft tissue operation around his shoulder, around his elbow, but we're not going to do anything with his arthritis. So it's okay. Just because you have arthritis doesn't mean you have to do anything, okay? So we're not doing anything with him as far as his elbow arthritis. Now here's a picture of a wrist. So here's your thumb over here. Here's your small finger over here. These are 8 little bones in your wrist. Now this is your radius, your forearm bone. This is your ulna. Now, look again here. See how we have pretty good spaces between these bones? This is a fairly healthy looking wrist. How about down here? Nice spaces between these bones. So when we have good spaces, what does that mean? The cartilage is okay, okay? So this person doesn't have arthritis. We didn't x-ray them for that, but this is a good representation of what a good looking wrist is. Now, side view here, that looks good. You'll just have to take my word for it. A lot going on there. Now, look at this fella. So here's the thumb here. Small finger's over here. Small finger here, thumb here. Now, do you see anything different about that? Yeah, he's got a clear space here and here, but how about there? No. Look at that. Now, look, that's a bone called the scaphoid. Now, watch this. We're going to look back at that. See that? That's a normal scaphoid. That's your nice little lima bean scaphoid. Now, what happened here? Well, this is someone who damaged this bone 30 years ago tackling the fullback, and he damaged the bone enough that it became avascular. He got a post-traumatic arthritis to this bone, and so the bone dies, which means you have bone rubbing on bone here, you have bone rubbing on bone here, and then progressively the wrist shrinks up like this, and then you develop arthritis here like this. So, same things we go through, anti-inflammatory medication. Now these folks, they'll have a lot of motion loss. I mean, their wrist may move like this. And surprisingly, we put shots in this sort of thing, and it helps. I don't know how that helps. He's got a dead bone in there, and he's got arthritis everywhere, but we put a shot in, and it helps for a while. Well, when the shot doesn't work, then what can we do with this wrist? Well, there's kind of arthritis all over the place there, so we don't really replace wrist joints. Now, that's not always true. Someone that has a fusion on one side, you don't want to fuse both sides, so then we there are wrist replacements that you can do. But the bones are so small, the implants don't stay in there very well, wrist motion is all over the place, and so they fail. And so for someone that's sitting around watching the birds migrate and has a very low activity level, it might be something that you would consider doing, particularly if they had the other side fused, because if you have the other side fused, it's hard to do things, hygiene and otherwise. We'll just leave it at that. So this person, what we did is we fused the wrist together. So we took away all the motion. We put this enormous plate and screws in there, and then we put bone graft in here. And this is a very meticulous operation. You go in and you scrape away where all this hard bone is. Like I told you, it's like the countertop here. And my thumb is going to need something done from doing this operation because it's wearing it out. So we take away all the cartilage surfaces. We put this plate in there. And then we put you in a cast for 6 weeks, and your fingers are out. But we're trying to get that wrist fused solid. Now, people that don't have much motion to begin with, they'll trade a little bit of motion for no pain. That sounds reasonable, doesn't it? Particularly with the wrist. We have people that have wrist fusions who go back and dig asphalt and dig holes and do things. They can't move it anymore, but it doesn't hurt. Doesn't wake them up at night and doesn't hurt. Now, assuming the bone fuses. Now, this plate and screws, it looks big and massive, but it will still break if the bone doesn't fuse to the bone. That's the goal. The plate holds it till the bone fuses together. And then we don't try to take this out. Sometimes in thin folks, it irritates tendons and things, so we have to take it out. But we don't like to do that. But this is an operation, wrist fusion. The wrist does not go up or down anymore. It doesn't go side to side. But it can go palm up and palm down, and you can use your fingers. And it's a good trade-off. Okay? Now here's another pattern of arthritis. This isn't quite as nasty as the one that we saw 2 slides ago, but this one, again, arthritis here, but you can still kind of see that bone's alive. There's a wide gap here. This is a very characteristic pattern of arthritis called scapholunate advanced collapse. Okay, a bunch of big words. I like the acronym. SLAC. Okay. Slack wrist. Now, people will develop a characteristic fluid bump over their wrist, so you can walk in the room and look at it and go, that's a slack wrist. And you say, when did you hurt your wrist in the past? And many of them will tell you, I was wrestling a steer, and 30 years ago, my wrist swelled that big, and it hurt, and then it just kind of got better, and I lived with it. What they did is they damaged a ligament here between these 2 bones, so then you get eccentric motion of those bones. You don't get concentric motion, and you develop an irregular wear pattern, and you get arthritis between this bone and this bone. Well, this person had pretty good motion, and some of these other joint surfaces actually look pretty good, so we did what's called a limited fusion. We take out this rascal over here who's causing all the trouble, and then we fuse these 2 bones together here, and they have some motion left. Now, people will ask, how much do I have left? Well, I wish I could tell you that. I don't know. There are so many things that are out of your control and my control as far as an operation goes, and a lot of that is how much does it scar? You know, we don't have control over that. If it scars a lot, maybe you don't move very good afterwards. But fairly reliable. We get this bone to fuse to here where there was arthritis. We remove that one. And this is a limited wrist fusion that does then save some motion. Okay, here's one that this is like low back pain. Everybody gets this. So every gal gets this. Sorry, men is a little different pattern of arthritis. But here's the thumb, here's the small finger, and these are nice spaces here. You get the idea of, well, there's some of that white stuff Smith was talking about over there, and I know that's not good. Again, side view, just have to take my word for it. We're not really interested in that picture, but here's the money picture right here. So this is your end joint right here. This is your middle joint right here, and this is your base of your thumb joint right here. Okay? So this is a common enough pattern of arthritis that we have a homework on this one that we hand out in the office. We only have about 6 or 7 pamphlets, and this is one of them, so it's pretty common. Every gal over the age of 60 has this pattern of arthritis. Now you can see right here is where there's supposed to be a nice joint space there. Let's see, we have a... supposed to be a nice joint space right here. So this is bad base of the thumb arthritis. Now again, we talked about how sometimes arthritis in the upper extremities can burn itself out. Okay, it doesn't hurt. It's not a weight-bearing joint. We have people that come in that break their wrist, and we're looking at the broken wrist, and we look at this X-ray, and I'll ask them, does your thumb hurt? And they'll say, it hurts so bad. For about 2 years, I thought I was going to go crazy, and then it just kind of stopped. Okay, now that's not everybody, unfortunately, but that can happen, all right? So we try our splinting shots, various things. If they don't work, then what we do is there's a very reliable operation where we take out this bone, we borrow a tendon here, and we roll it up, and we put it in there as a spacer. Okay? And it's awesome for pain relief. It's a rodeo to go through because you have a splint on for 6 weeks and you're mad at me for 3 weeks and you're calling Marlo over there and telling her you're mad at me, but it is a good thing in the end, okay? Most folks really like it. Now, here's a pattern of arthritis where you can see this bone's a lot too long, isn't it? So it bangs into this bone right here. You develop a cyst here. This joint really looks kind of bad. Now this person's going to have a lot of problems going palm up and palm down. It's going to hurt. So, but the rest of these joints look okay. So what do we do with this? Well, it kind of depends on the age group. Now the Mayo Clinic is really working on a joint replacement for this joint. they're still working on it. It's been a long time. Good people trying to figure this out, but wrist is a complex joint. It's hard to do replacements on. So the easiest thing to do here is you go in and you just cut that out and stabilize the soft tissue over here, but we get rid of the banging of the bone here, and we get rid of the arthritis here, and this is very reliable operation to recover from. Now here's ArchNemesis of many fingers in here. Everybody hold up your hand who has crooked fingers. Okay? Okay? So here, again, we have some representations here. This is a gal who owns part of the wing at the surgery center because she's had a lot of surgeries done on her fingers. But this joint right here is one that we fused in the past. You can see how it just looks like one bone from there to there. Now, here she has, this is erosive arthritis here, and it's at this end joint. It's at what's called the DIP joint. So you get erosive changes there. It's really hard to put a steroid shot in there. I mean, we do, and it works, but there's not much joint space there. It's just little, and it hurts like the devil to put a shot in there. Okay? So when she was having none of it, the shot stuff, she's like, no, this one feels great. Let's go for it over here, too. So we open it up. We take the joint space away, saw off the ends of the bone. Then we have to have some way to fix it, so we put pins down it, and then we hold it still for 6 weeks, and we hope it looks like that. So you get a stiff finger here that doesn't hurt anymore. Okay? Now these middle joints here, they're called the PIP joints, and they are the worst joints in the body for getting hurt and not recovering. They're terrible. They're just hateful things because, one, it's really hard to do anything surgery-wise there. We have some joint replacements for those joints, but candidates, they don't work all that well, and people wear them out, and then you have a worn-out, unstable joint with an implant in there that doesn't work. So many of us have just quit doing it. The other option is you fuse this middle joint. Well, that is not a very good operation because you have to kind of fuse it either in a little flexion so that people can still grab things, but it's always like that. So fusing it like that, the end joints are okay. You can almost fuse them straight. But the middle joints, they're terrible to deal with. And we just try to do shots and say, until somebody thinks of something better to do, it's hard. There are some replacements, and there are limited candidates for that. These joints here are very amendable to joint replacement in certain people. Now, if you're hanging sheetrock for a living, you don't want to have a joint replacement there because you're going to wear it out. Okay? If you're done doing that sort of thing and you can't sleep at night and you can't grab your grandkids and that sort of thing, and we've tried all the other things, then we can do a joint replacement there.